Good morning, and thank you for joining us at the 2021 El Camino Health Heart Forum. My name is Jane Lombard, and I'm the Medical Director for the Women's Heart Center. Today, I'm going to talk to you about women and heart disease and what we do at the Women's Heart Center. We take care of women who already have cardiovascular disease and also women who are at high risk for having cardiovascular disease. We also take care of women who have conditions that are primarily affected in women, and that of course includes pregnancy. So we have a budding cardio-obstetrics program. Finally, I will share with you what we do in cardio-oncology, which is a program that takes care of women who suffer from side effects of cancer treatment, side effects that affect the heart. So, heart disease in women. What's the difference between men and women? This graph depicts the historical prevalence of heart disease in men and women over the last 60 years. As you see, in the 1980s and 1990s, the death rate for women exceeds the death rate in men when it comes to cardiovascular disease. In the late 80s, statins were introduced, and you see the blue line, which represents the men, the death rate starts going down. However, the red line remains unchanged and actually still continues to go up. So women are underdiagnosed and undertreated when it comes to heart disease. In the early 1990s, the WHI, or the Women's Health Initiative, demonstrated that estrogens didn't really help prevent heart disease. In the late 1990s, generalized hormone replacement, or HRT, was stopped. And in the early 2000s, a public education campaign, the Red Dress campaign, was introduced by the government and the American Heart Association. And with these three interventions, you see the red line start coming down and actually crosses the blue line for a very short period of time in the early, about 8 or 9 years ago. But as you see, both lines are starting to go up, and that's not good. So what's the difference between men and women? Well, women tend to have more atypical symptoms. Instead of just chest pain, we sometimes have back pain or arm pain. There's a lot of shortness of breath, and I see women with nausea, dizziness, and a lot of sweating. These unusual symptoms tend to delay diagnosis, leading to longer times to treatment. And we say door to balloon, that means longer times to get angioplasty or stenting. This causes worse outcomes and, of course, longer hospital stays and higher death rates. Women also are undertreated when it comes to risk factors such as high cholesterol, high blood pressure, and diabetes. Women have more side effects from medications, particularly blood pressure medications. And all these causes increased cardiac mortality, particularly in young women. And at the same time, the American public is becoming less healthy, more obese, and more sedentary. With all these changes, there is increasing inequities in healthcare. Now I'm going to share with you some conditions that primarily affect women. These conditions demonstrate how physiology in women can be so different when compared to men. The first is spontaneous coronary artery dissection, or SCAD. 90 to 95% of these patients are women. Usually they're young women. And 17% of SCAD patients suffer SCAD in the peripartum period, usually right after delivery. And this cohort is extremely young, the average age being 35. And the rest of these patients, I would think, are still pretty young, with an average age of 48. SCAD may be associated with fibromuscular dysplasia, which is kind of like scarring inside the arteries, and neither one of these entities are well understood, so we need more research. Another condition that we see that primarily involves women is Takosubos. Takosubos is also known as broken heart syndrome. Most of these patients are women, usually elderly women. And this condition is precipitated by intense emotional stress or severe pain. It is related to the sudden surge in adrenaline. The adrenaline causes the arteries on the heart to constrict and limiting blood flow. And this causes the heart not to contract. And so in this picture, you see the heart muscle sort of ballooning out, forming like a vase-like structure, or as the Japanese calls it, takosubo, an octopus pot. Fortunately, most patients recover completely, but again, it is very unusual because most of these patients are elderly women. Another condition is Monoka. Monoka is a relatively new term. It stands for myocardial infarction or ischemia with non-obstructive coronary artery disease. When patients have a heart attack, we do angiograms to determine if they need to have an artery open or stenting. And we find that 5 to 6% of all heart attack patients do not have an obstructive lesion or blockage. This is called Monoka. Most of these patients tend to be younger women. They have fewer traditional risk factors such as hypertension, diabetes, or high cholesterol. This diagnosis is made after all other causes are excluded. Cardiac MRI or PET scans may be helpful. The pathophysiology is attributed to microvascular disease or small vessel disease and endothelial dysfunction. Unfortunately, we have no big randomized studies to tell us what's the best treatment. And also, 25% of these patients have persistent symptoms such as chest pain or angina. Now, you all know these pictures. Well, one picture. This is Whistler's mother, originally titled Study in Black and White. And there's my friend accepting the Getty Challenge, posing as Whistler's mother during the corona pandemic. So we're going to talk about pregnancy and heart disease. There are two key points I want to bring up about pregnancy and heart disease. One is the immediate complications and the cardiovascular causes of death in women around pregnancy. And the second is how pregnancy can be associated with an increased risk, a future increased risk for cardiovascular events for a mother. Now, this slide is from the CDC, and you can see over the last 20 years, there has been an increase in maternal mortality in the United States. Unfortunately, we rank very poorly among rich and developed nations as far as our maternal mortality is concerned. Cardiovascular disease is the leading cause of maternal mortality in the United States, and that is probably due to an increased number of women, mothers with acquired heart disease. We also see an increasing number of women with congenital heart disease who are now older and surviving to reproductive age. So currently, we have 17 maternal deaths per 100,000 live births. 26% of all U.S. pregnancy-related deaths are due to cardiovascular causes. And when you include hypertension, stroke, or other thrombotic causes, this number goes up to over 50%. And this is related to the change in risk profiles of American mothers. We're older, there's more extensive use of IVF. We have older mothers with congenital heart disease, etc. The Cardioobstetrics Clinic focuses on early detection, prevention, and management. And another pointer on cardioobstetrics, African American moms do worse. They have about 38 to 39 deaths per 100,000 live births, almost double the white population. The other very interesting thing is how adverse pregnancy outcomes can affect or be a harbinger of future cardiovascular events. What's an adverse pregnancy outcome? An adverse pregnancy outcome includes preterm birth, stillbirths, IUGR or intrauterine growth retardation, or basically very small babies, multi-gestational pregnancies, so twinning or triplets, etc. All those are associated with almost up to fourfold risk for future cardiovascular events. And 10 to 20% of all pregnancies are associated with an APO. Now, this may be because the placental dysfunction and endothelial dysfunction share a common pathway. The placenta is a very large vascular organ. So currently, the American College of Gynecology and Obstetrics, ACOG, recommend that women with adverse pregnancy outcomes and other cardiovascular risk factors undergo screening within 3 months postpartum. And this is a picture from the CDC trying to make public a educational campaign regarding maternal health. Finally, a few notes on cardio-oncology. So what is cardio-oncology? Cardio-oncology is the diagnosis and treatment of the toxic side effects of cancer therapy on the heart. The therapies could include radiation, chemotherapy, antibody therapies, and more recently, the targeted T-cell therapies. We are seeing more patients with complications as there are more cancer survivors living longer. And of course, there are new drugs invented almost every week. Cardiotoxicity may be manifest as heart failure due to cardiomyopathy or weakness in the heart, arrhythmias, which include ventricular tachycardia and atrial fibrillation, hypertension, heart attacks, blood clots, pericarditis, valvular disease, myocarditis, vascular disease, and cytokine release storm, which is a massive immune response, systemic immune response that is pretty rare but very lethal. All drugs have different side effects, and sometimes these patients are on a combination of treatments for their cancer. This ends my talk. So I thank you for your attention. And this is the Sobrato Pavilion where we're housed on the first floor. And if you have further questions or need an appointment, this is our contact number. Thank you again and have a great day.